you see me?
Not yet.
Yeah, so could you just bring your screen? We'll start sharing it with you.
Yeah, well, I've opened my camera. I can hear you.
Yeah.
Let's see what happens. Otherwise, I will open it differently. There, I can see you. Good morning.
Yeah. So just share your screen. Just share your screen so we can know.
Yep. Screen. I'm disabled. Can you make sure the host let me share?
Yeah. I'll let it. Yeah, you can share once, Luis.
Okay, let's try that again. Okay. Share. So you can see that. I can put it in full screen mode. Let me just move the.
Yes, seen well.
You can just move the slides and check also.
Yep. I'll put that full screen. Okay, you can see that.
Yes, we can. Yeah.
Very well. Clear.
Okay.
Okay. Hiteshwar, would you like to share your screen?
Yes, ma'am. I can share. Here it is written, you cannot start screen share while the other participant is sharing.
Yeah.
So
I think you can stop sharing, Luis, then we can check if Hiteshwar's is coming or not.
Okay.
Is it coming?
Yeah. Yes. Okay. And Dr. Ramkumar, you'll be speaking just as it is, right?
No, I plan to use slides. I sent you the slides this afternoon. May I check mine as well?
Yeah, please.
Sharing the screen once the page goes off.
Yeah.
I'll make it full screen. Making it full screen. Is that okay?
Yeah.
It's full screen now.
No, your screen share. Your screen is not being shared.
Oh yeah, sorry. Yeah, now it should be, I think. Is it?
No, not yet.
Okay. Yeah.
Yeah, now it's sharing. Yeah. Okay. Yeah.
Great. Okay.
So I think we wait for the other participants to join before we start.
Yes. Tell me how much time, in what order do we go and how much time do we have?
Yeah, we start with Dr. Ramkumar, then you, and then Hitesh. And then Parthu will give the summing up and the final remarks.
Okay, and it's a total of 1 hour?
Yeah, 1 hour, 15 minutes. So I think you and Hitesh and Dr. Ramkumar have 1 hour. And then we can, then Parthu has the rest of the time for summing up.
Okay, so I won't go beyond 10 minutes. And if I find that there's too much material in my talk, I will skip a few of the studies that we did. The studies are there to show that long-term growth is not impaired and nasal correction remains. But if I see that I'm a little short on time, I will skip these, and then we can have more time for this.
No, you have a lot of time, so I don't think we should be short of time. You can share all your studies. Would you like to just check whether the video is playing?
I'm sorry, the video is playing, Wes?
Yeah,
we can check.
Yeah.
I will share again. Okay, full screen. Okay. Do you see them now?
Yeah. Yes,
Okay.
yes.
I wonder if there is a delay between my image and yours.
I don't think there's
There
much
might
of
be
a,
a few seconds delay between the two.
I don't think there's much of a delay.
Oh, good. Very good then. Okay, and the other one, it starts automatically and I can speak as it goes. And if it doesn't work, I will not stop. I will just move on. I will explain what we should be seeing and I'll move on, because if we try for you to open the videos and come to the right spot, I think we can always return to it later if need be. What do you
Yeah,
think?
I think that can be done.
Yeah, because particularly if there is a couple of seconds between what I say and what you can see, I will never know whether you're taking over or not. So if it's only to show the active videos, I will say that for some reason the video is not playing, we can return to it later and we'll continue my talk.
Yeah, okay.
Okay.
Partho, do you want to say anything for the...
It's fine.
It's fine. Okay. So I will come back and I'll stop sharing. Voila. How often do you do these webinars?
Yeah, we're doing them quite often now that everybody's at home. So people are enjoying this. Yeah.
This is my first one. I did not attend any webinar during this lockdown period.
Next week, I'm doing the Canadian course on the ear reconstruction. So I'm doing more and more of these from the cottage because I'm not busy. Tomorrow I'm operating. I'm doing class tomorrow, but I operate once a week. That's it.
That's right, Luis. The joke now is that with the COVID pandemic, webinars are becoming epidemics. So there's more and more of it happening, and it might be that we may move more towards webinars in the future.
Yes.
Speak to the comforts of your home.
Yeah, it is
Exactly.
comfortable.
We normally have 7 o'clock in the morning meetings every week. And now I've been taking these meetings from home, attending the meetings from home. And I don't think I will ever go back to being in a meeting at 7 in the hospital. I'll do them all from home with my coffee now.
So somebody is recording it? Anjana,
Yeah, we are recording it.
Okay.
Am I clearly audible?
Yeah, yes, you're clearly audible.
Not me.
Oh, 2 more minutes.
Yeah.
Approximately how many people registered or something like that? Is
We
there
didn't
anything?
have a pre-registration, but usually going by our other webinars, around 100 people, between 100 plus minus.
Okay. I don't think in Cleft so many people will come.
Yeah, let's see how many join in the Cleft thing. Actually, for aesthetic and all, they have a lot of
Yes.
people joining.
At present, we have a 19, including 5 of us.
Yeah.
Participants 15.
Yeah, so we wait for some more time because sometimes people take some time to join in before we start. I think we'll take another 5 minutes before we.
Sure.
So in the meantime, I'm just asking Lewis, are you using pre-surgical molding?
Not very little. When it first came out, the NAM, we thought it was very extraordinary and we did it for a few years. And now in unilateral clefts, I've stopped using the nasal part of it. very early, because I found that you stretch the mucosa so much, it's flat, you stretch both skin and mucosa. So when you round up the nostril, the mucosa, you have way too much mucosa that you've been stretching with the NAM. So that we've stopped the nasal part, and now we've also stopped the passive oral plate for the unilateral. I still use the oral plate and taping for the bilaterals just to correct the angle of the maxilla so that I can close in one setting the bilateral clefts. But I don't find that it is very helpful. It hasn't changed our results. We didn't do surgical orthodontics for 20 years, and then we did it for some years, and I don't think it makes much difference. It doesn't change our results.
When you used it, did you find any difference in outcome so far the nasal appearance is concerned?
No. When we started doing NAM, then we thought that this would be the correction, and we stopped doing the nasal dissection for a few patients, and then we realized that the correction that we obtained with the NAM was not maintained. You would have to use stents in the nostril for a long period of time. So we've returned back to the comb subcutaneous dissection with the sutures, temporary sutures to hold the cartilage in place, and we don't use NAM at all anymore. What about yours?
There is a message that's come in saying that our voice is very low. So I don't know, we're all speaking fairly loudly. I could hear you, Luis, and I could hear the rest of.
Yeah, I can also hear very well.
Yeah, I am also hearing very clearly.
Actually, I think the thing is, if you don't hear clearly at times, it's your own internet connection which is the problem at times. So
maybe the person in his output, volume output is.
Yeah, that could also be so.
So
We've got 31 participants. I think we wait for another 5 minutes and then we start. Okay.
So, Lewis, again, I'm asking, when you do a closed section of the cartilage, you dissect only the cleft side cartilage?
Well, you have to go on the tip, because remember, the movement that we want to do is superior and more medial towards the normal side. So you have to dissect the nasal tip, both the affected side and the other side, so that you make room for the cartilage to move. This is the typical McComb publication many years ago. McComb used to put his stitches way up on the glabella. I like to put the stitches lower down because it's easier to place the cartilage, but the sutures are temporary. You remove them after, I remove them after 12 days.
And you do it subcutaneous?
Yes, no nasal incision. I don't like the nasal incisions. I've seen some children that had nasal incisions when I traveled, and I've seen nostril stenosis. So I think we should stay away from intranasal incisions.
No, I'm saying you don't dissect it from the mucosa.
No. It's very difficult to dissect the cartilage that is very thin from the nasal mucosa, and I think we would do more harm than good. It's only subcutaneous. And when we do that laterally, there is a risk that the nasal mucosa will not reattach with the skin, and that you will have a wide base of the nostril. So it's very important to plicate mucosa and skin together at the end of after the dissection. Once you've put the nostril where you want it, I use 5-0 plane sutures that I leave there. We used to put bolsters, but we stopped doing bolsters because you create more nasal obstruction for breathing. So we only put the bolster up at the top in the dome, and we don't put bolsters laterally. And you don't get stitch marks from the 5-0 plane that goes from outside from the crease into the mucosa.
Effacement kind of sutures.
I'm sorry?
It's like fusing the mucosa with the skin.
Yes, you plicate. You want to make sure that you don't leave a dead space where you have dissected under the skin. You don't want the mucosa to pull away from the skin. And you have, it's already in all clefts, it tends to be a web inside the nostril because of the stretching of the mucosa that has happened when the nostril is stretched. by the muscles. Once you release the muscle, we can bring the nostrils where we want them.
Yeah.
But there is often a web inside this. So that's why you need to really plicate mucosa on the skin.
Okay, so we are going to start.
Yeah, we're going to start, I think. Good evening, all the members. I welcome all of you to our 5th webinar of the Association of Plastic Surgeons of West Bengal. And this is being done in association with Cleft Mission Smile, which is again an organization, non-governmental organization working towards transforming lives and bringing smiles since 2002. So this Mission Smile has the vision of providing compassionate, comprehensive cleft care, and the values are based on the values of equality, dignity, and empowerment of every child. And the mission is a cleft-free India. It's an NGO run by Indians on Indian funding. So this organization delivers its work in 3 modes. 15% of work is done on missions, where the whole team goes into an area where there is no proper, cleft surgeons available or no cleft work is going on, performs 50 to 100 surgeries in a week, and then sends a smaller team for a follow-up. Our main mode of delivery, of course, is the Guwahati Comprehensive Cleft Care Center, which I think is one of the best cleft care centers in the country. It performed 1,251 surgeries in 2018-19 and accounts for 51% of the workload. Again, there are many outreach centers which are run by the organization, where again, we do a lot of cleft work. So this is the state-of-the-art surgical facility at GC4 or Guwahati Comprehensive Cleft Care Center. They are running fellowship programs. So those of the PGTs who are interested in learning about cleft are welcome to visit here for a month or 3 weeks as they so desire. And this center has everything from speech therapy, dental, nutrition to child life support. So the mission is, if not us, then who? And if not now, then when? So that is the mission of Mission Smile. So now we begin this webinar. We've got for you very adept people in the cleft craft. To moderate this whole webinar is Dr. Partho Sadhu, who needs no introduction to our members. He was the past president of the Indian Society of Cleft Lip and Palate and Craniofacial Anomalies. He is going to take the questions at the end of the session, and he is also going to give his expert comments. So we begin with Dr. Ramkumar Venkateshwaran, who is the Chief Medical Officer of Mission Smile and was the ex-head of Department of Anesthesiology in Manipal. He is going to talk to us for 5 minutes on anesthesia issues in these children, because this is very, very important. Then today we are just going to deal with unilateral clefts, which is going to be taken on by Dr. Louise Laberge, who's the Chief Division of Plastic Surgery at Hospital Saint Justine in Montreal, Canada. And she will share with you her technique of unilateral cleft lip repair. Bilateral cleft repairs, lip repairs, and other craniofacial malformations and other tessia clefts we will do in a subsequent webinar. And to conclude with his talk on palates and the repair, the radical muscle dissection, we have Dr. Hiteshwar Sharma, who's the medical director and the chief plastic surgeon of Guwahati Comprehensive Cleft Care Center, or GC4, where till today about 20,000 cleft surgeries have already been performed. So I now request Dr. Ramkumar to please start off the webinar. Dr. Ramkumar, please.
Anjana, could you please, thank you. I'm starting my slide sharing. Can you see my slides, please?
Yeah, they come up. It started. Yeah, they should come up.
Okay. Right. And can you hear me well, Anjana? May I start?
We can't see your slides as yet. We can hear you.
Okay. Right. It's already saying you're sharing, screen sharing.
It's come up. Okay.
It's come up, right?
Yeah.
And the voice is okay. May I go ahead?
Yeah, you can start. Dr. Ramkumar, you can start your presentation.
The screen on Dr. Ramkumar is showing very low bandwidth. So he's having a problem, I think, Dr. Anjana.
Yeah, okay. I think we'll just wait. It will come up. Just a minute. Otherwise, yeah, okay. Yes, Dr. Ram, we can see you. Could you start, please? Dr. Ramkumar, you can start now.
His microphone is off. He's mute.
Oh, he's mute.
Dr. Ramkumar is mute. His microphone
We are unmuting him.
Yes. Okay.
Yeah, he started, yeah. Dr. Ram, please start.
Sure.
Dr. Ram, could you start? Hello?
On days, yes.
Yeah, Dr. Ramkumar, please start your presentation. Yeah, I think if we are having problems, Dr. Ramkumar is having some problems with his bandwidth.
Okay. I think I'm being repeatedly muted. So now I've been unmuted.
Yeah, so you can start. Yes, please do start.
I'm so sorry. Right. So since during the embryological development at the time when the lip and palate are forming, the heart is also getting formed. So it's quite natural that associated heart defects can also be a problem. With the airway of the patient being involved, the anesthetist needs to do a very focused airway evaluation.
Dr. Ramkumar, we can't hear you. Hello, Dr. Ramkumar, we can't hear you. Hello? I think as we are having...
Dr. Anjana, I think, with the low bandwidth, with the screen sharing and the thing, just Dr. Ram can speak. Yeah, Dr. Ramkumar can speak. I think it will be better.
Yeah, we'll now go on to then the unilateral cleft lip deformities. And may I ask Dr. Lewis to please start her presentation?
Good morning. Can you hear me?
Yeah, we can.
You can. Very good. It's a pleasure to be with you this morning, and I thank you for this kind invitation. And I'm pleased to see that we already have 62 participants to this. My talk will be on unilateral cleft lip surgery, cleft lip and palate, but you will understand that it's more about correcting the middle third of the face. It's not only the lip that is the problem, it's the whole middle third of the face that we need to correct. So I'm trying to advance the slide. Let's see, it doesn't seem to work now. Okay. Let's see if that will work better. If you'll excuse me, some technical problems here. Can you still hear me?
Yeah, we can.
Yeah, it's surprising because I'll stop sharing and see what's happening because my slides were advancing well before. So I have to understand why it's not advancing now. Okay. Down. Share screen. Can you see this?
Yeah, we can see it. You can start, please.
Okay, I'm trying. Okay, we have to understand the defect. So as you see the child with the open lip, and you see that there is also a deformity of the maxilla and the nose. The cause for the deformity is the abnormal muscular insertion. The orbicularis, rather than being as one unit around the mouth, is attached to the nose and the premaxilla, thus creating the secondary deformity of the maxilla and the nose. You can see that the anterior nasal spine is moved over because of the deformity of the premaxilla, goes towards the normal side. So does the septum. The ala, rather than being around and having a dome properly placed, is totally flat. The angle between the nose and the cheek is flat. And this is the mucosa that continues directly from the nose into the mouth on both sides of the piriform aperture, which is open. The piriform aperture is also widened. So it's important that our correction will address all of these components because they are interrelated. And if we only bring the lip together, we will be left with a deformity that will not self-correct. So it's an approach to correct the deformity as one unit. We want to close the piriform aperture and the alveolus, which is the base for the lip and the nose. The nasal reconstruction is a good time to do it because we have access to the nose. And finally, we want to bring the lip together, and the key to the repair is the muscle reconstruction. We have to preserve the cupid's bow and align the vermilion, and it is not really important which type of skin incision you like, whether you like the fissure that gives very nice result, if you like Tennyson or if you like Millard. I happen to be using Millard for many years, so I stick to it. And we all do variations of whatever technique we decide to adopt. But I want to be clear that it's not really the skin incision that makes the correction. It is the muscle. So I use the Millard, as I say, a modification of the Millard, because I like the incision to be straighter than the curved incision already described by Millard. But whatever works well for you, it's important to find the landmarks of the lip, the cupid's bow, and look at the width of the vermilion. As you come along the cleft, the vermilion becomes narrow. So it's very important that we keep the tissue laterally to widen the vermilion on the medial side to produce a symmetrical lip. This is the dissection of the lip. The lip has been dissected, and it gives you access to the nasal tip. This blunt dissection will be in between the medial cruray of the alar cartilages. And as you can see, we move over towards the normal side so that we create space in the middle and the tip area to be able to move the alar cartilage. The alar cartilage is lower on the cleft side. So you notice that we have not made an incision in the nose. We've only used the incision from the lip to access the nose. We continue the dissection here on the vomer side, on the septum, so that we can reflect the mucosa that was continuing from the nose into the mouth, which is normal, and we can bring this down. It is an inferiorly based mucoperiosteal flap. You can see the elevator there, and the dissection comes anteriorly to meet with the dissection on the premaxilla. As you can see, the mucosa will face towards the mouth once the dissection is done. We have not interfered with the attached gingiva. We've brought the dissection from the premaxilla all the way back to the piriform aperture, to the incisors foramen. You can even develop this flap all the way posteriorly. Some people do that, and they close the anterior hard palate at the time of lip repair. It is a very good time when the lip is open for you to be able to close the primary palate, because you can see so well. So once we've done the medial dissection, we'll continue with the lateral dissection. Same principle. Again, it's a modification of the Millard. I like to keep on the lateral side, I like to keep the incision around the nostril very, very short, because you will see that we do subcutaneous dissection, and we don't need to make an incision around the area. Someone is, okay. So we want to find the muscle that is attached to the base of the ala and free it from the nose for two reasons. First, because if we leave this muscle attached, you will always have a deformity of the nose. The nose will tend to widen because of the muscle pulling on it. And second, you need this muscle bulk to bring it midline and block the rotation of the central segment. So the advancement of the muscle is the key to the lengthening of the central segment that is too short. So we really need to free this muscle at the base of the nostril all the way down to periosteum. Here you can see that the muscle has been freed. It gives you access to the subcutaneous area. It is above the lateral cartilage, the alar cartilage that your scissors is dissecting, and you're coming to reach the medial dissection that was done earlier on the medial side. So you can go slowly, come all the way. You can see with my finger all the way where the dissection is being done on the tip. This dissection was first published by Dr. McComb from Australia. Here you can see a temporary stitch that is being put where we think the dome should be. So you put your forceps within the nostril and you push the tissue, and that gives you an idea where the dome would be. If it is not the right location, you can replace the stitch later on during the case or at the end, and that will give you a stent. It will give you a traction to keep the tip of the nose where it should be. And this is very important, because if we don't place the tip of the nose where it should be before we start closing, what will happen is when you try to raise the nostril tip where it should be, you will shorten the lip. So this is the lateral dissection of the mucoperiosteum. You see that the blade is sectioning mucoperiosteum all the way down to bone. And what you're seeing now is the piriform aperture, which is wide. You slide your elevator underneath the periosteum, and you can have a lot of tissue laterally because you move under the lower turbinate. If you look at the top, there is a drawing with the red line and a green line. You can see the movement of the mucosa. Okay, so this dissection now releases the lateral aspect of the nose and will bring medially the piriform aperture and the nose. It is the reason why you need no nasal incision to bring the nose where it comes, because everything comes together with the periosteum. So once we've done our dissection, we can start closing. We place the nasal tip where it should be with the traction suture. Then we close the primary palate, because when everything is open, it's very easy to close the primary palates. Once you've closed the lip, it's very difficult to come back and close a vestibular fistula. And once we close the primary palate, we continue on and we bring the cheek mucosa, the lip mucosa, to join with the primary palate and close totally that area. And then we will adjust the ala and the skin. So we start in the back. The suture comes from the oral side. So we're facing the midline flap, the green flap on your image. That has come down, and then we take the undersurface of the lateral flap. The two flaps will slide one on another. It is a two-layer closure. So the wider the cleft, the less overlap there is. The narrower the cleft, there is more overlap. But this is a very sturdy closure because there's no tension on it since you slide your flap one on another. And you make your nuts in the mouth, so it's much easier to do. So you will see the nostril rolling in and coming like that. Once you have closed posteriorly, you put in these sutures. And now you see that I'm closing the oral side, so it's end to end of the nasal oral side, and now we're doing the nasal side end to end. So it's truly a two-layer closure, and you bring the structures where they belong. So this one will bring the base of the nostril, the mucosa comes up towards midline.
Louise, can I ask a question?
Yes.
The alveolar cleft that you've shown,
yes,
is not very wide. I mean, it's wide, but it's not very wide. And if the cleft is wider than this, in my experience, you actually need to put a gap. I mean, I do it more or less what you said, almost exactly what you said. But in a situation where the alveolar cleft is very wide, I've often found, as you said, this sliding that you said that happens, it doesn't actually come to that extent. And what I have to do in those patients is I put in a gag and I actually go back on the palatal side onto the vomer and actually go further back and raise a V flap. I mean, I do like a V advancement to allow that sliding to happen. If you see what I mean. It's a little hard to explain because it's not in 3 dimensions.
Yep. Actually, I find it easier when the cleft is a bit wider than what we see here on my side because you have more room to work. And since we have the two advancing flap, if the cleft is wider, as you say, they will overlap less. If the cleft is narrower, they overlap more. And if it overlaps less, as long as they touch one another, it doesn't really matter because it does re-epithelialize. So I've never done another flap for that. And if you don't mind,
yeah, I mean, I actually tend to follow the Oslo technique in which we close a lot of the hard palate using the same technique, going further back so that, in the second stage, there's only quite a small posterior flap posterior cleft to close in the later stage. So okay. I would say I would do like a third of my palatal closure in the hard palate at the anterior palate closure. A little more than you do. I mean, you do a bit, and I would go further back and do a little bit more. It helps us
exactly.
Maybe because one of our problems is the patients don't always come back on time to get their surgeries done, and very often we get the first surgery when the child is about 6 months, and then the child just goes away and then comes back after a year, by which time it's a year and a half, and it's a little bit later. So if my palatal closure is pretty much closed at that time, then I only really have a small, I mean, I would have taken some, I could have shown some photographs of what I do, but I'm not really very, this is the first time I'm doing a Zoom thing.
May I request all of the participants to please ask questions at the end of the presentation?
Okay, thank you.
So that the presentation goes on. Yeah.
Carry on.
I agree with you. It's nice when it's a wider cleft, so we have more room to work, but then it's a little more work to close it. Okay, so now here we see the closure on the nasal side, and if it was a wide cleft, as you say, we'll leave a little gap because it doesn't matter. I'm double layer. So here I want to draw your attention. This is the lip mucosa that is coming to meet with the medial vomer flap. So this is actually closing the alveolar cleft and the nasolabial fistula. Do you see that? This is the lip mucosa. Again, the lip mucosa continues on and comes all the way medial until we meet with the medial side. So it will be, the sulcus will be totally closed. So we don't leave a fistula, either a vestibular fistula or an oronasal fistula. We close all of it when the lip is still open. Much, much easier to see. I want you to pay a minute of attention on the forceps that I have there. The forceps are actually used with on the extra mucosa that I will get rid of at the end, and it helps me put the tissue together without having too many people assisting me. Okay, so a few technical details. The upper portion of the lateral muscle is fixed to the base of the columella above the medial muscle fibers. And this is what I was referring to earlier. It is the way to keep the rotation from the central segment has to lengthen, and the rotation will bring down the central segment. If we don't put anything at the top, this will recur. And that's why some people say that lips tend to shorten. The lip will shorten if there is nothing on top of what you have released. So it is the muscle that was at the base of the nostril that comes medial, and it will do many things for you. It will centralize the columella. It will maintain the inferior rotation of the medial segment, and it will bring your lip together. So this first stitch is probably the most important stitch of the whole repair. And I like to keep the muscle attached to the skin. I release the muscle very little from the skin, maybe 2 millimeters, 1 or 2 millimeters, only to be able to put the stitches in the muscle. But I want the muscle closure to bring the skin together so that I don't put sutures on the skin. Very, very few sutures on the skin. I just put isoacryl on top so we don't get stitch marks. So I will put a few very fine 6-0 plane on the vermilion and the mucosa, but certainly not on the lip skin as much as I can. The vermilion repair, as you can see, the vermilion is shorter on the medial side, and we use the extra vermilion from the lateral side, and I like to close it in a zigzag. So the lateral vermilion will come in, and then the medial mucosa can lengthen the lateral mucosa, because I have brought all this mucosa from lateral, so sometimes it is a bit short, particularly because the maxilla on the cleft side is more posterior than the premaxilla. So you will see a difference in the mucosa showing, so you can adjust that with your flaps at the end. In incomplete clefts, these are cases where you will see that the lip is longer on the cleft side, which is I don't think I've ever seen in a complete cleft. So make sure that you pay attention to that, and that you shorten the muscle when you do your primary closure. I always like to bring the muscle together before excising any of the tissue in the nasal floor, because it's easy to narrow too much nasal floor. If you were to measure now on this pre-op slide the amount of tissue you want to remove from the floor, you will overestimate. So wait. You can free the muscle, bring the muscle together, and then you look at the floor of the nose once the columella is centralized and the ala is symmetrical, and then you decide if you need to remove any tissue from the floor of the nose. What we can get immediate result is usually maintained. So what you see at the top of repair is what will stay for you. You see here again that there's only glue on the skin, and you can look at the nasal symmetry that we can obtain at the time of lip repair. We looked at the long-term results of nasal symmetry on 51 children with complete unilateral clefts to judge how much symmetry we could obtain. And we looked at different measurements. We looked at first the projection, the Eller dome symmetry, when you look at the light reflection, and this was symmetrical in 68% of the children. Then we measured different components of the nostrils, and we compared with the normal side. All the children in the studies were 6 years old. It was before they had the bone graft, and none of them had any revision, neither of the nose or the lip. But they're all what you get with the first surgery that I showed you. So we always compared the nostril on the affected side with the normal nostril and expressed the results in percentage. So if you had a perfectly symmetrical nose, you would have 100 for all the dome projection would be exactly the same number. The nasal height would be exactly the same. If it was shorter, then we would say this is 80% of the normal, or 85% or 90%. This is how we express the results to compare the children. So look at the nostril height that we would compare with the other side. You see, very often, this is the nostril height that will be affected, and the rim to dome height will be lower in a cleft. Typically in a cleft, the rim to dome will be lower, the nostril height would be lower, and the nostril width could be wider, okay? So that's what we looked at, and we compared them. So in the 51 children, we obtained 100% on all measurements. That would be height, the dome projection, the dome to here, everything, in 11%, close to 12% of the children. So everything was perfectly symmetrical. Then we had a very good symmetry. They were above 95% in all measurements for all this. So this would be another 35 children, 35% of the children. So roughly 50% of the children were very symmetrical when you looked at them after 7 years. And then we had good symmetry. It's not perfect. You can see that here the dome is not exactly symmetrical. And you can see in these children, there was nothing done to the septum. So you can see that the septum is off, even though the columella is centered. This happened in 37% of the children. Then it was fair. So it's not bad, but it's not symmetrical. And this is the most affected measurement, the tip to alar rim. This happened in 10% of the children. And in another 5%, for some reason, it seemed that nothing was done. It's an asymmetrical nose, even though I think it did the same surgeon, did exactly the same thing, didn't seem to hold. So I think it is a good surgery that improves our result and does not add any scar and doesn't take very long. It probably adds 5 minutes to your repair because everything is done subcutaneously. You put a few stitches, and it is a good improvement on your results. So these are typical. We have the chance to follow our patients until they're 18, and we live in the country where people don't travel that much, and we're not so many. So I typically see my children until they're 18, and now, considering I'm a grandmother, I'm now operating on the children of the children I have operated when I was a younger surgeon. So this is an example of a complete cleft, and her result at 2 years and 16 years, and the only thing that was done to her was her bone graft when she was 10 years old, and we just let her grow. Another example, 3 months, that's at birth, 6 years, 14 years, and you see her when she's 16. She's had a 3 months repair that you saw, a year palate. She had a pharyngeal flap at 4, 10 years, her alveolar bone graft, and a septoplasty when she was 17. And this is her CT scan. She was missing the lateral incisor, so we looked at the thickness of the bone graft to see if she could have integrated osteo-integrated implant, which she did. So that's her bone scan prior to her osteo-integrated implant.
Hello.
We also looked at the results of our secondary alveolar. Did you speak to me?
No, please continue. Please continue.
Okay, we looked at the results of our secondary alveolar bone graft in children because since we close the primary palate at the time of lip repair, we think that having all the soft tissue closed in the area that we're grafting puts us in a better position for bone grafting. So we looked at our result 2 years ago, and our rationale is that if we don't have a fistula and we don't have any opening, we won't have any problems with the tissue coverage of our graft, and it should be good. So The previous closure of the primary palate provides required mucoperiosteal flaps to bridge the bony defect between the alveolar segments. So the protocol in our center, it's the orthodontist who's the person who decides when the graft will be done. We typically like to do it before the permanent incisors comes into the alveolus, and we harvest from the hip. And we like that this is very, very small, so it's easy to compact it in a syringe and insert it and cover it. We don't do any individual tooth movement prior to grafting unless there's a tooth that interferes with the surgery. But we don't like to move the teeth at all because you want to keep the teeth well covered with bone. If the tooth is exposed, then the bone graft doesn't heal quite as well. And we don't stabilize the premaxilla prior to grafting, even in bilateral clefts. We looked at all the graft we had done between 89 and 2005. All the bones were done before 15, all the grafts were done before 15 years of age. And we assessed the graft height according to Berglund scale. In cases where a repeat bone graft was done, the occlusal radiograph that was assessed for the study was after only the first bone graft. So we looked at the result after one bone graft. So this is the Berglund scale that you may be familiar with, where you see the amount of bone that is in the space between the teeth. So that would be a Berglund 1. It is a normal height. And here you can see that it is 75% of the height. Here, less than 75%. And 4 is then when there is no union. So to be able to do a tooth movement in the bone graft, we need to have a Berglund 1 and 2. This is considered a good result. The Berglund 3, normally, often you'll have to regraft to lower the bony segment. And in a 4, you need to regraft before moving a tooth because it will not be supported. So when we looked at our patients, we had 160 clefts in unilateral, 118 bilateral clefts. Lip cleft of the primary palate only, we had 58, for a total of 336 cleft. Some clefts we're not able to classify because there is a tooth that is blocking the view of the occlusal. So there is 7 clefts that we're not able to classify because we could not see the rim of bone because it was hidden by a tooth. So we had a total of 309 clefts that we classified. And we looked at how many of those obtained the Berglund 1 or 2, which is what we are aiming for. And we had 75% almost, and 15% that were Berglund 1 or 2, so a total of 90% only needed 1 bone graft at the time. And as you know, the bilateral clefts have a lesser the prognosis is not quite as good. And even in the bilateral clefts here, we are over 90%. And what has the best prognosis is the cleft of the primary palate. And again, we have almost the same results. So we had only 1 patient that was a graft, Berglund 4. So when we look at the unilateral and the bilaterals, there's really no major difference between the 2. And when we looked at the cleft of the primary palate only, again, it is not significantly different. It means that all our cases do well. So we had the graft failure of 3, when there was a if there was no fistula, we had 95%, almost 96% success rate. If there was a fistula, you can see that we have a lower success rate. Usually, if we have a fistula in our population, it will be at the junction of the primary palate and the posterior palate because these are done in 2 separate settings. So the fistula is usually more posterior. And I'm sorry, this is the same. So in conclusion, closure of the primary palate resulting in the absence of the oronasal fistula seems to have a positive impact on secondary alveolar bone grafting. The redo of the bone graft is quite rare in our practice. So we also looked at the septal growth in teenage years. you can see that even though we have a symmetrical tip with the alar cartilages, when the septal cartilage grows in teenage years, then we still have a deformity. So in the recent years, we've been bringing the septum median in the center at the time of lip repair, but I don't have long follow-ups on that, so I won't discuss it now. Here we can see that not all the clefts have the same growth potential. So we looked at, we tried to see if the fact that we were using a vomer flap at the time of lip repair would create more retrusion of the maxilla. So we looked at complete unilips, unilateral cleft lip and palate in 34 children with no presurgical orthodontics. And the lip and palate, the primary palate was closed at 3 months of age and the palate at 1 year. And we compared our result with the Eurocleft and the Toronto study. We measured the usual parameters for maxillary position, and we looked at the position of our children. So here are the Eurocleft centers when we look at the SNA values, and you can see that the best center was the center B, and we have differences here, and the Toronto, and this is the Montreal group. So we can see that the SNA value is certainly not tempered with doing the flap. You can see that the controls, either the Michigan or the Montreal controls, are here. We know that the cleft children as a group don't grow as well as the normal. So this is the SNA that shows the position of the maxilla. Again, the SNB, you can see that in this group, the Eurocleft A has slightly better results. And again, you can see that the Montreal group follows with the best centers. Again, the S and P here. Again, the Montreal group is very close to all the others here. And this is with the Toronto base for the anterior position of the nasal spine. Very similar. The vertical part. So we can say that the maxillary growth in our cleft population is comparable to the other groups included in the Eurocleft study. And when we compare the maxillary length and position, it's also very similar to the Toronto group. We don't think that the presurgical orthodontics is needed. We don't use it very much. We've almost stopped using it in unilateral clefts. So the fact that we close the primary palate, but the lip closure does not impair growth. It does give us a better position of the to do the alveolar bone graft, and the nasal correction that we obtained at the time of lip repair, the tip nasal correction, is maintained. So in my opinion, complete correction of the lip, nose, and primary palate provides better results that are maintained with growth. Lip revision are rare. In our practice, less than 5% of the lips need redo, and the nasal revisions await teenage years. We don't reoperate on noses when they're 8, 9, or 10. I don't think that preoperative orthopedics is essential for surgical correction, and I certainly don't like aggressive pre-surgical orthopedics by fear of interfering with growth. You've seen certainly publications showing that aggressive orthodontics and the periosteoplasties does interfere with growth. It's not what we see. Alveolar bone grafting is easier. The primary palate is already closed because there's no fistula, and our results compare favorably with published series. If the lip seems short after primary repair, it may be due to poor support at the base of the nose because there's no bone yet and the lip is sinking in. So I usually prefer to wait after the alveolar bone graft to adjust the lip if it's needed. And of course, nobody is always right, but the first surgeon has the best chance, and I welcome a good discussion. Thank you very much.
Thank you, Louis, for a different take and an excellent take on the way of repairing the primary palate. We'll have questions at the end of the presentation. So may I now call Hiteshwar to talk upon the palate repair. Dr. Hiteshwar Sharma, please.
Thank you, ma'am. Am I audible clearly?
Yeah, yes, you are.
So I'm sharing the screen, my screen. It's shared?
Yes.
Okay. So good evening, everyone. Today I'm basically speaking on primary palatoplasty. So why I choose this to speak on this topic, because most of the young surgeon and the young cleft surgeon, they actually very much they have a fear of doing palatoplasty, and most often the palate surgery is so much uh, is something very critical like that. If you do something wrong with the palate, it's very difficult to correct later on. That's why it is something like that. One sort of opportunity you will get to do something in a palate, and you have to do right thing in the right time. So, so what is the aim of the palatoplasty? Why we need to do palatoplasty? So, traditionally, we learned that the speech is the primary goal for palatoplasty. Second is the facial growth, and third, which is not often mentioned in any of the text, nobody is mentioned about. It is a separation of oral and nasal cavity. This is also very important when we started a survey of patient satisfaction in our center. So we have found that most of the patients, they wanted to do palate surgery. They're adults. Despite of explaining that that your correction will won't give you any good speech, but they wanted to have their surgery. After surgery, they find some confidence in their attitude, and this is because when you separate the oral and nasal cavity, you are separating the two cavity, which is a different flora and fauna in your oral cavity. So complete different environment you are creating inside the oral cavity. So that helps them to build some confidence in facing the society and facing the public. So that's what I am adding. The another goal is that the separation of oral and nasal cavity is very much important also. Then, traditionally, there are two schools of thought in a palatoplasty. One always focusing in the lengthening of the palate, and based on that thought, that several procedures have been described. One is like Farlow's palatoplasty, buccal flap, myomucosal flap, then anti-attack repair. These are the main goal is that they have here. They wanted to lengthen the palate. And another school of thought, they always go for the good anatomical restoration of the muscles. And typical example you can give the somatic type of muscle dissection. And they say that once you repair the muscle very correctly, and muscle will start acting, and it will pull the palate backwards and upwards, and finally it will reach the goal of palate lengthening. But nowadays, most of the surgeons combine both the ideas and modify their techniques and procedure and apply both in palatal repair. So different types of cleft palate. We know that various type of classification has been followed in the book, but practically we always like to say a complete unilateral, complete bilateral, incomplete soft palate only, posterior hardened soft palate only, secondary cleft palate, and submucous cleft palate. Secondary cleft palate, sometimes we can say the complete secondary cleft palate also, which is in our Indian classification, like Indian classifications given by the Balakrishnan, that is group 2 cleft palate. So that is also sometimes put in the complete cleft palate. But virtually, when we speak to some colleagues or some friends, practically we always use these are the terms to use the palatoplasty. So these are some photographs of brush up our memories. Yeah. This is the submucous type of cleft palate, and this is the posterior hardened cleft palate. This is an incomplete variety, and complete variety is the complete unilateral cleft lip and palate. This is the complete cleft middle. We see the vomer that are simple. This is the right side of the oral mucosa, and on this slide we see the vomer is the midline foot protruding foramen, and this is a bilateral variety of cleft. So my presentation is very basic for the young stars. So different types of palatoplasty. is a two-stage closure and one-stage closure. We can divide into two. The two-stage closure keratoplasty and one-stage closure keratoplasty. The two-stage closure idea developed when in 1931 Waddell Kilner, they started the pushback type of keratoplasty. There is a big raw area anteriorly they found, and it produced a very ominous results like growth, with face growth retardation like that. So two keratoplasty, then the idea is developed by Dr. Swetendek. He developed the idea. So they repair in the first 6 months. They repair the soft palate along with the lip, and they wait 4 to 5 years. Not he waited for 12 years. Now they have modified the procedure. Now they are waiting for 4 to 5 years. They close the hard palate at 4 to 5 years of age. In one stage closure, always there is another procedure we add, which is a velar myoplasty. So we can say keratoplasty comprises of two things. One is the cleft closure, another is the muscle resection and the myoplasty. So here the different procedures are the von Langenbeck type of bipedal flapectomy, VWK pushback technique, Bardak type of keratoplasty, Harlow tabuloplasty, buccal myomutation flap, alveolar extension. These are the ones this procedure is followed. Here is a schematic diagram which shows the basic structure of the flap, where this is Langenbeck type of repair, where the nasal layer is repaired. Then there is a raw area on the bipedical flap, which is raised entirely attached to the alveolar margin. This is the VWK, which is not often used nowadays, and there is an anterior peristeum is left. Then whole palate is repaired and pushing downwards in back to give a raw area and grading. And because of that raw area, it is easily avoided. Then it is replaced by nowadays a Bardak type of keratoplasty, where it is small anterior most mucoperiosteal part also included in the flaps, and flap is raised till at the dentoalveolar margin up to that. The flap is raised and the cleft closure is done. And last was the Harlow keratoplasty, which is often found very complicated. But one punchline has to be remembered, that all the posteriorly based triangular flap should contain the muscle. That has to be kept in your mind. All the posteriorly based triangular flap should contain the muscle. If you remember that line and if you try to repair it, it's very easy, not very tough. So Langenbeck repairs, there is raw area on both sides and suture line in the midline and entirely attached to the alveolar margin. Then Harlow's, where the G-plasty is made, and basically Harlow would like to do in the incomplete cleft or soft palate only. Mostly nowadays Harlow is followed in secondary palatal surgery to lengthen the palate. Then Bardak type of two flap keratoplasty, where in the Bardak type there is the incision line is at the palato gum margin. There is a leave the gum aside, and another is the AEP, where in case of very wide palate, if it is very narrow, then we use the gum margin also including the flap. This is popularized by Michael Kirsten, but I personally don't like to go for AEP because it might injure the tooth bud of the alveolus. So we have to be very careful doing this procedure. The another procedure is a Hans Pistler vomer flap. So in this case, we can see the very wide vomer, which is repaired at the 6 month age, and this vomer tissue has reflected like a page of a book and attached to the other side, and then lip repair started. Followed by that, you can see after 8 months or so, the whole anterior palate looks like very nicely repaired. Then you can repair the soft palate with the muscle resection line. So this is another procedure which is, but nowadays people have complained that this is procedure also produce a bit of mid-phase refusion. So now what to do? We have to somewhere put a draw a line and we have to decide what to do, what not to do. So in our center, we follow a certain kind of protocol for addressing a cleft lip and cleft patients. So prenatal counseling we do in parents if parents reports uh, uh, before the birth of the child. If cleft patients has been detected during prenatal ultrasonography, then parents report to us. We do counseling, we show them photograph, we make them understand and help them to and prepare the parents to for the child. Then after birth, the breastfeeding is always a problem. So child eventually might go for a malnutrition. And nutritional counseling we always do, showing the best way of breastfeeding like that. 6 months we do. And at the 6 month of age, we do the lip surgery. And where we expect that patient should have a 6 kilogram of body weight at least. Then after lip repair, we follow the patient up to 6 to 12 years to body weight, so that at the 1 year of age we do the palatoplasty. Now this 1 year is also controversial. Some people do at 9 months, some people do at 20 months. Some books rate written in that it is 12 to 12, 24, 12, 24, 18 to 24 months palate repair. So I will come that later on, but we do at the 1 year of age, the 10 kg of body weight. Then we the follow up the first 1 week, 2 months, 6 months, 1 year, and 5 years. These are the follow up along with the speech follow up. 5 years are, but I must say 1 year and 5 year follow up are very difficult to get the patients. This is because of poor patients compliance. Once patient is satisfied with their surgery, they never turn up the doctor's follow up. So what procedure we do? Procedure usually depends on type of palate deformity. So there, as I said, the two procedure. One is procedure for cleft closure. One is the palar myoplasty. So we do not go for 2 stage. We do the 1 stage palatal repair. So for complete cleft palate, we go for a Bardak type of palatal two-fab palatoplasty, which or without tumor flap for nasal layer. In incomplete cleft palate, we go for the Langenbeck type of repair, and all cleft closure techniques are combined with the levator myoplasty. That is the must to do levator myoplasty. The cleft closure techniques, what a plastic surgeon needs to learn is that good light, the position as per surgeon convenience. Patient is supine, neck extended, and typically the anesthesiologist put intubated and the RA tube should be fixed at the middle of the lip. Then we go for the infiltration. First we put the mouth gag, then infiltration. So infiltration, there are different opinions are there. So what we do a mixture of cocktail anesthetic agent which contain the lignocaine 1%, 0.25% bupivacaine, and 1 in 200,000 adrenaline. So what we do 20 ml of 2% lignocaine and 20 ml of 0.5% bupivacaine. We mix in properly, and which makes the volume double, so that it became 1% and 0.25% bupivacaine. Then followed by that 40 ml, we add 0.2 ml adrenaline, which is with a tuberculin syringe. You can easily get small disposable. We can add it there. So the dose of that solution is that 0.5 ml per kg and up to 0.75 ml per kg you can give safely. And if you need more, then we can do hydrosection with normal saline. We infiltrate the palate. And 3 ml lower lock syringe we usually use, which is lower lock is basically now we need a tremendous pressure to do the hydrosection so that the bill should not eject out. Always use sharp and fresh blade. I use number 15, so you can use the number 15 blade. It is so fresh that even if in the middle of the surgery, if you want to change, please change it, because more the sharp of the blade and good dissection will be always. Then we need a good suction. You see, usually in a very young kids there is not much bleeding, but in adult cases it's really bleeds. Suction should follow the knife. During dissection, if you are very new, you can ask the resistant, put the suction near my knife, so that as the knife goes, the suction will go along with the knife. And delicate tissue handling for palate is the must. Specifically, the medial edge of the palatal flap, when we raise the flap, the medial edge, we should very much take care of the medial edge, because that medial edge forms the midline suture, and there is often chance of getting fistula at the midline if you more catch in the medial side of the flap, or if you burn some bleeding in the flap in the medial side. So never do anything in the medial side of the flap. Rather, we can do the holding suture in the palate to in a peripheral flap. Then better to use the bipolar pottery, but if you don't have, if you have the monopolar, you can use polar dip monopolar pottery, and as well as you try to locate the bidding point very precisely before cauterization. First of all, avoid cauterization, and if you need to cauterize, you do it polar dip monopolar or bipolar pottery, and you do with very precisely locate the bleeding point. And most important point for the young surgeon is that always go very slow. Never be very fast, very go slow. I can remember the first surgery when I did the palate surgery. It takes 3.5 hours for me to raising the flap to complete the things. 3.5 surgery, or I feel it is more than 4 hours also. But my colleague said that it is 3.5 hours. So, but nowadays, when I start doing surgery and practicing it, and now this come down to almost around 1 hour, I can finish one palate surgery. But there is always a learning curve, and we have to follow the learning curve. We should not be shortcut on that learning curve. Then carefully release the pedicle from the ligamentous attachment to get the greater mobility. This is a very careful, very delicate point. I will show in a picture, in a schematic diagram, where to ligamentous. This is situated behind the pedicle. It is tightly attached to the base of the hamulus, as well as some of the tensor platini, tensor aponeurosis, which is attached behind the pedicle, which is very tightly. If we release it suddenly, we give a very mobile oral flap. So you can see in the diagram, you can see the pedicle, behind the pedicle, when the bony edge is in here, and if you follow the bony edge, so you can very blindly you can follow the bony edge, because pedicle is always inside through the bone. So there is always a bony gap between the pedicle, through the pedicle. There is a bone, and then you come to the muscle. So you can follow the bony edge very clearly, and just behind the pedicle you find that some fibers from the tensor is coming and just attached to the base of the pedicle. That fiber should be severe, and as soon as you have the fiber, you will get a very good mobility of the oral layer. So in that way, you can close whatever may be the white palate in your cleft. You can close very easily. So most of the surgeon thinking that very wide flap is not coming despite of releasing, but it never happens. And moreover, it gives a very much mobility, so that there is a very less chance of fistula in the midline. Then I'm going back to slide. Now we need to split the soft palate at the level of when the hard palate ends, the soft palate start. So at the that level, we split the hard and soft palate again, and to find completely separate the nasal layer and the oral layer. And we always found the levator muscles, which is attached lying on the nasal layer. So we mobilize the mucosa, nasal mucosa, with an instrument like I use this this instrument. You can see in my picture. This is a Freyr's elevator, which I use to mobilize the nasal mucosa and completely. Then, Sushar use the 4-0 polyglactin. We commonly say the bacteria to repair the nasal mucosa. Then, for cosmetic purpose, we always go for the uvula repair because always public, always patient, parents always ask for the good uvula. So once you suture all the nasal layer, it should be look like that. There should not be any bleeding because once you split in the right plan, there should not be any bleeding. So this is the after suturing the nasal layer, and see the medial edge that should be free of any trauma, any injury, any burn. Even if when I took the holding suture, I took it in the glands, in the mucosal glands, and pull it away. So I did not use the edge. So to dissect the lift the muscle, this is the incision line at the base of the uvula. It is around 5 millimeters from the midline. We start we start making the incision from here, and which is coming closer to the midline at the near the bony attachment of the muscle, like that. So similar to the other side also, we follow the same incision line, and here is always when you put the knife here, you always find some hitting points from this area. Probably some tubular vessels you will find it here, and immediately cauterize it. Otherwise, when you go for muscle dissection, this is a small bleeding will trickle, and it will obscure your field, and finally you end up with a very big hole in the nasal mucosa and a very poor muscle dissection. So for a good muscle dissection, you have to have a very clear bloodless field. And if you feel that there is oozing is not controlled, you can do one thing. You can soak a gauze with a adrenaline solution and put it for 1 minute or so, and just take a rest. Then again start go for dissection. And you will see the very clear film. Whenever go for muscle dissection, it is good to if you have a very magnification. Like 2x or 4x magnification of loops if you use. But personally, I am not using any loops. I do with a bare eye. So this is this is another patient with bilateral with a two flap plastic. Flap has been raised. This is the same after nasal mucosa repair. The same way the incision should be made like this. This is the bony edge film. So from there we cut it, and although in the lateral side we will find usually their tensor fibers and the levator fiber, intermingled levator fibers. There is a junction you will find. So please follow that junction always. So we have dissected like that, and hold the tip with your dissecting forceps and try to lift and find a small space to see the blue mucosa. And this incision should be very sharp and very fine, so that you can reach directly to the blue nasal mucosa. And after that, you just lift the angle with the forceps, and then push with the dissectors, like what I have just shown, that Freyr's elevator or peristyle elevator. You just gradually push the muscle, and the muscle will easily come up, and this is the mucosa you will see. Muscle will come up, then try to free it from the lateral side also, and go laterally, and the aponeurotic part to separate from the muscle and go depth. If you go little deep, you will find there is some gap, and that gap is actually the levator tunnel. That tunnel should be exposed. If you pass your instrument to the tunnel, that will go up to the base of the skull. So that tunnel to free all your muscle in that tunnel, so that it's freely mobile. The muscle should be freely mobile. And one more advice is that do not catch the muscle in between or do not try to burn the muscle, because once the muscle is scarred, then we won't get the good muscle functional muscle. Same with the other side also, we lift it out and dissect it out. So after that, there is a very good repair. So as Dr. Lewis said that in the nasal floor repair, there is something like that type of repair. So similarly, we can put similar type of overlapping repair in the center part of the posterior part of the palate, the muscle repair, and which produce sometimes what we can make a big ball of muscle inside here. So tension should be adjusted. It should not be more tense. It should not be more loose. This is another picture of good muscle repair. You can see clearly the very nice dissection. The Karchi to Dr. Partha. So I took the photograph from his presentation. So this is very nicely, we can see the muscle here coming from lateral side. And here we can see as well the tensor fibers. So we dissected from tensor fibers. And as I said that the levator tunnel, through this, if you go further in this junction, you'll get the levator tunnel. So this is the ideal dissection of the muscle. Okay. Then after that, we close the oral layer, from before backwards or from the uvula to the anterior part, whatever is visible, we can do the oral layer. We do the transverse mattress suture in the oral layer. Edge should be inverted, and transfix the oral flap with 1 centimeter behind the tip of the palate to the nasal layer. I do not put any suture to the dental gum margin, the flap, oral flap, because dental gum margins are very unreliable. Most of the time, this gum margin are unhealthy. Within 2 to 3 days, the suture will fall off, and there will be a hanging palate. So always put the suture through and through transfixation suture with the nasal layer, 1 centimeter approximately posterior to the tip of the repaired palate. Then feeding, we start as soon as the child is fully recovered from anesthesia. We start with the liquid, and over 3 weeks we do after first checkup, if everything is fine, we go for some semi-solid. Then after 3 weeks we go for the soft diet. Then after 1 month, child is allowed to have the normal diet. So what we do intraoperative, 1 injectable antibiotic followed by postoperatively oral painkillers. Already I inject the palate. There is lots of local anesthesia, and that will prevent another 3 or 4 hours postoperatively. So the pain is not a big problem. So give liberal amount of painkillers and antibiotic syrup for 5 to 7 days postoperatively, and patient can be discharged the next day. Of course, we found complications. So bleeding is the immediate complication we found. So all bleeding should be tried with a packing. Most of the palatal bleeding stops packing, but if there is a very fast flow and repeatedly collection, if there is a clot formation inside the oral cavity, that is the ominous sign, and we take the child for re-exploration. And mostly within 24 hours bleeding occurs. Then fistula is another problem, which is what we do. We follow up the fistula to repair after 1 year. And why 1 year? Because it requires a certain time to get back the tissue, get back to its normal behavior. And that's why we always take the 1 year. Some surgeons repair in the little early also, but 1 year is the optimum time. So once fistula develop, so we should not hurriedly repair within 6 months or so. Most of the time, the refistula chances are very high. Of course, the other big problem, which is the VPI after palatal surgery. So for that, evaluation and secondary procedures are there. We can address those things in the separate issues. And mid-facial growth retardation is another very big problem with the palate. That's depend on the timing of the surgery. So people say that if you do surgery early, there is more mid-face growth retardation. If you do surgery later, speech outcome is very poor, but mid-face is okay. So my opinion is that if someone asks me if what do you want to give, either good speech or mid facial growth, I will always say for good speech, because speech is a very difficult thing to give a uh, child rather than mid face growth. If child develop a mid face growth retardation, then there is always another option of mid facial advancement surgery at the age of 18 years or so. But once we lost the speech, it's very difficult to get back the speech with however, whatever you do the surgery, whatever the very big surgery you do, but it is very difficult because speech development is associated with the human brain and muscle coordination that is also always related. So there is a particular time of learning. So when you go for a speech therapy in a very early, the results are good. When you do very late, the results are getting very poor. So also the speech is some kind of that if you repair adult palate, you first make the adult patient to unlearn whatever he or she learned, uh, and then maybe again relearn the things, how to produce the sound with their muscles and coordination. So that is very difficult. So that's why, so I particularly give the emphasis on the speech development rather than the mid-facial growth retardation. Of course, both are the problems, so we have to find the optimal time. So that is the debate which is going on, and the people are trying to find out what is the optimal time for palate repair. There are lots of studies are there, but usually it is said that around 9 months to 1 year is the optimal time for 9 to 1 year, or typically say 2 years speech time. That is the duration where you have to repair the palate. So finally, I must say to the young surgeon is that the palatoplasty is not a very big thing, but it is a part of a very big responsibility. So responsibility is to regulate the child in the society with a good speech and good facial growth, and palatoplasty is a part of that for the ones. Thank you very much for patient hearing.
Thank you, Hiteshwar, for the excellent presentation. And now I hand over the proceedings to Dr. Partho for his comments and taking question answers. Dr. Partho, please. Partho, please unmute yourself. You're muted.
Can you hear me now?
Yeah, we can. Yeah.
Okay. First of all, Anjana, tell me how much time we have.
Yeah, you can go on. I think you have 15-20 minutes. People would like to hear the final.
Okay. In the meantime, if there is any question comes in the chat box, we will look after it. Right now, there is no such question. There was a question from Rajkumar Misra from Lucknow, which Luis already answered. He wanted to know the primary palate repair, how much posteriorly you can go. And Luis very correctly mentioned that as much posterior you can go is better. So in fact, when we do a conventional vomer flap, we go right up to the junction of the hard palate and the vomer. Anyway, so not a matter of discussion. I will ask a few things to Luis and Hiteshwar. That is, Luis, when you take that vomer flap, you take that incision. Am I audible to you?
Can you repeat the question when I do the vomer flap?
Yeah, when you take that incision just behind the anterior nasal spine, you see the clean white septal cartilage.
Yes, yeah, you expose the lower portion of the septal cartilage,
Yeah,
and that gives you an opportunity to release the foot of the septum from the anterior nasal spine. There is a ligament holding it there. So for the last 5 or 6 years, I've been freeing this ligament at the time of lip repair. But I didn't mention it today because I don't have long-term follow-up to show you and show you that it doesn't cause any problem. But by freeing that the anterior inferior part of the septum from the nasal spine allows you to bring the septum midline to follow the rest of the correction, and it helps.
Yeah, that's why I am saying, is it not better to call it a inferiorly based septal flap than vomer flap? Because you are actually not going to expose vomer.
You're totally right, and I've been arguing that over the years, but everyone calls it a vomer flap, so that's why I didn't change the terminology. But you're totally right. It's a quadrangular cartilage that we do expose, and not the vomer.
Because vomer flap is totally technically different. My second point about your incomplete cleft, you mentioned about long lip. But if you carefully see in most of the cases, you will see the ela of the affected nose is also at a lower level, because the width of the piliform aperture and the floor of the nose is also at a lower level in the skeleton.
And
so actually, most of the time I measured, they are not long lip, they are displaced downwards, which gives an appearance of long lip most of the time. So I personally call them pseudo-lengthening. What is your opinion about this?
You're perfectly right. When we look at the contraction of this muscle on an incomplete, you will see there is a gap on top of the muscle bulge. So you have to bring the muscle higher up, because the lengthening is in fact that the muscle is inferiorly displaced. I totally agree with you.
Yes. Yes. And about the septum, it has been seen that doing a septoplasty actually does not hamper any midfacial growth. It has been proved long time back, because there was a good study with pediatric trauma where all the children with midfacial trauma and facial trauma, they saw, I do not remember the number nowadays, it was more than 400 cases, that very few of them had actual fracture, nasal fracture, all these things. And they found that the fractures which involved the sphenoethmoidal junction only, they had facial growth problem. So doing a septoplasty and straightening only the cartilaginous part actually does not hamper any nasal growth or midfacial growth. And we have been following it since 2000. And because initially I was also not doing, but all the children grow with a carved nose. So it is always better to correct the septum and remove the piece of scroll from the inferior border during the primary lip repair. What do you think?
I agree with you. And I think the bad reputation about the septum, if we, you know, in the old days, they used to say if you interfere with the septum, you will cause a problem with growth. But I think that the cases where they had the problem with growth after septal surgery or septal trauma was more with the hematoma. So if a child has a major hematoma and develops necrosis of the septum, I think that is the reason why it does interfere with growth. We had the same concern before starting to work on the nasal tip. We were afraid that we would cause harm to growth, and indeed we do not. And when we do the vomer flap, we do not hamper growth either. So that we have looked at, many people have looked at that.
Yes. And about your sulcus, is it absolutely necessary to bring down the Cupid's bow?
I like it. I like when I release the central segment, I want to be able to bring it as low as I can. So if I want to suction, you know, some people are very attached to the frenulum. They never touch the frenulum, and it's something that is a landmark for them. Yep. I don't care. If I want the lip lower, I will section the frenulum, and I can always bring the lateral mucosa into it. The same kind of advancement that I do on the skin, I do on the mucosa.
Exactly. And in your secondary alveolar bone grafting, you talked about bringing down the lateral incisor.
I talked about the lateral incisor.
How? Permanent incisor, permanent lateral.
Okay. Well, our indication for our timing for the alveolar bone graft goes mainly with the canine position, because we want the canine to come into the bone. Because if I do the bone graft very early and I have an empty piece of bone for 2 or 3 years before the canine comes in, there is more thinning of the bone and we don't have such a good bone quality. Sometimes, I think you have mentioned that before, we will do an earlier bone graft to support an erupting lateral incisor that would be on the lateral segment. And we will do that particularly when you have not the same level of bone on the lateral side and on the medial side. And what we do, we go very early before the lateral incisor comes out, because once the lateral incisor has come through the gingiva, we cannot lower the bone. If we go early, we bring down, we cover the lateral side to bring it down and force the lateral incisor down. So it happens from time to time. Most of the time we don't do that, but depending on the position, we do.
How often in a complete cleft you really get the permanent lateral?
How often in a complete cleft do I?
You get the permanent lateral incisor.
We think that to have a good permanent lateral incisor that stays there for orthodontics, probably half of them are, at least 25% are never there. You never see them. Another 30, 50% have small lateral incisor with small roots that actually do not withstand orthodontics that well. So we probably have 30, 40% of our children at most who keep their lateral incisors, and sometimes we will widen that tooth. If there's enough teeth, then we'll do a dental closure of the cleft, migrating the canine tooth into the defect. If we don't have enough, then we'll keep the space and we'll put a osteo-integrated implant. We tend not to put dental bridges because it harms the teeth on either side of the cleft.
You mentioned in the evaluation of bone grafting with bar glands and taking occlusal view of the X-ray, and you told in one case it was not possible to understand because of the position of a tooth. So in this condition, why can't you use a cone beam CT scan to know it exactly the cortex?
Well, you certainly can do a CT scan. That study I was quoting was a retrospective study, and we were looking at our results with only the occlusal film. But if we want to know, if we need to know the height of the graft for a clinical case, then we will do a CT scan. But we don't routinely do CT scan on all of our bone grafts. It will be a lot of CT scans, and we don't need it. We'll do a CT scan when we need to evaluate exactly the thickness of the bone because we have a concern for tooth migration, but usually we don't need that.
In Eurocleft study, you compared your results mostly with the group 2. And group 2, if I'm not mistaken, was Gothenburg. So regarding the facial growth, it was the Gothenburg team. And their protocol was entirely different from yours. They did a soft palate with lip, and then they kept the hard palate open for 7-8 years during the Eurocleft study. So in spite of having a completely different protocol of facial growth, how do you explain that your facial growth is equivalent to theirs?
Well, because it shows you that this dissection does not harm growth. And we've had many very different protocols that give different results. And I don't think that it's a good idea to leave the hard palate open for 7 or 8 years. And we've never done that. So I certainly think that what we've been doing does not harm growth. And is it necessary to leave the hard palate open? I don't think so.
No. Now they have reduced the age. They have come down to 18 months. But during that time, it was 7 years. When the Eurocleft study was done, it was there 7 years. And my last question to you is, what do you consider as a difficult complete unilateral lift? Can you hear me?
I can hear you. Do I consider which type of unilateral lift would I consider more difficult?
Like you will be more careful.
Honestly, a lip is a lip, and you sort of know what you're getting into. If you want the cleft to be narrow or not doing cervical orthodontics, just do taping. In my usually when I have a wider cleft, I find I have more room to work, and it makes me quite happy.
Because many people, they think that a very short lateral element. So thank you, Liz. Thank you for your contribution. And
for a minute, I think Monish had some questions to Louis, so you can ask him if he wants to ask those questions now.
okay, okay. I have just one question for Hitesh. Can I ask it before?
Yeah.
There was a question about buccal flap, which Hitesh has replied. And I have only one question with this bardak with levator myoplasty. Like, do you have any assessment about your VPI incidence in your center? Because it's a long center with multidisciplinary approach and working in thousands. So categorically, non-syndromic unilateral
thing is like that.
1 year.
Yes, sir. Actually, in our center, we, as I said, that 1 year or 5 year follow-up is very difficult to get. But still, we manage. We have some kind of research collaboration with the Gothenburg University, and there we have shared some of our speech samples with them. And their assessment said that speech is more or less comparable to outcome is comparable to their outcome. It is not much difference. But problem is like that. Most of the patients who has been undergone palate repair, it is later in the phase of their life, after 6 years, 7 years, like that. So now we are getting for last 1 year, they're very small, each 1 or 2 years, we are getting the right time we are able to repair the palate. So, so those results, which are 5 years, 6 years patients, those results are often very bad, and some of the patients has very good results. So the speech sample, which the 50 patients speech sample is sent randomly from our center to the Gothenburg University, and their analysis and compared with the different speech therapies, there come, it is more or less comparable. There is no such very bad PPI, but still we have PPI patients who has been operated at the age of 7 to 8 years, and which has been
that is okay. Yeah, below
yes,
1 year, below 1 year. Okay, thank you, Hitesh. Now, Monizda, you want to ask a question to Liz?
Yes, I wanted to know from you actually, when you do the primary lip repair, do you repair the anterior palate and how far back do you go?
I go right up to the junction of vomer with the hard palate. And then I go down to the posterior border of the vomer to the skull base, and there I make an anterior back cut.
Yes.
So that the whole flap flips and goes right there. I did not touch my hard palatal mucoperiosteal flap almost ever when I do the residual soft palate closure.
Yes, exactly. That's also what I do. And do you put in a gag to do that, or do you just do it without a gag?
Sometimes just if you overextend the mouth remains open, and you need actually just 3 stitches for it.
That's right.
3 boxes for it. The mouth is open, just extend back, or just put a deep pressure and ask to pull the tensor a little. That's all, most of the time.
Yeah, I mean, I use a gag, but your eyes and Hitesh's eyes are much better than mine because you don't use magnification.
No, I do use magnification.
I know. But I've seen Hitesh doing palettes without magnification. I'm really amazed by how good his eyes are. But for older guys like us, I think putting a gag in. If somebody is doing a vomer flap, I would advise that you put in a gag and get a good view of everything, and it's easier to do. It does add 15-20 minutes to this operation, but my further question to you, Hiteshwar, and to Partho both. Currently, we are operating on these children in a situation where they might have COVID-19, and all these children have an uncuffed tube, and are actually breathing out an aerosol directly into the surgeon's face, which is currently the most risky form of doing any kind of surgery. I want to know from you whether you've actually started doing palate surgery, because I haven't done any lip or palate surgery for the last 2 months until some protocol was settled upon. And what are you and Hitesh doing?
No, I did not do any. I did not. I still not operating. I am, in fact, not in my center also. I am actually living in Durgapur now. I could not go back to Siliguri, and there is no work.
But what do you plan to do?
Yeah, what I thought about it, I must use something transparent between the patient and test level. It could be a table with clean glass through which I can see it, or maybe a clean sterile plastic sheet through which I will see, and my hands will be under the plastic sheet to operate. That is what I have thought about it. About any maxillofacial injury or palate surgery or something. That is what I've thought.
Sir, I did operate one palate case. Not, of course, my center is closed, but the one patient has insisted me to do in the private, so I did it. So I used the face shield. The face shield is getting easily available. You just put it in the forehead, and shield is completely cover your face. But your body is not covered, but face is completely covered. So that if anything with that face shield, you can freely do the surgery, no problem.
Yeah, but what about fogging issues? That face shield fogs a lot, especially if you're using magnification under the face shield. You don't use magnification, so I think that was easier.
Yes, I'm not using magnification. That's why it is easier for me to do the face shield. But if you're using loop, then of course.
Okay, what I've been doing my lip repairs, and I'm doing a palate repair this week. And what we are wearing, we have an N95. I have my loops on. I have my headlamp when I do the palate. I have a shield on top of that. No, I have another cover for the a hood, and then I have a shield. I'm trying to send you a picture because we look like monsters when we come into the room. And now we're supposed to start checking the COVID status for our patients so that we won't have to dress so much. I haven't had much problem with the fog, but with the N95, the fog is a bit different. You know, it does not come very much up into your loops. So I get used to it, but I look like a robot. I'll send you a picture.
I'm going to do a bilateral lip on Monday, so I'm hopefully going to be able. I think I'm talking about bilateral lips next week, right?
Yeah,
Anjana?
Yeah.
So I'll take a photograph of what I'm trying to do to set myself up to do the operation. But it is a problem for us. It is a problem for us because operating in summertime, it is now May, operating with a hood or whatever it is mask is very, very difficult, and operating with an N95 mask is much more difficult than operating with a plain mask. I did a microvascular operation last week, and it was absolutely a horrifying experience. And for 10 hours inside one of those PP things is absolutely horrible.
Yeah, I think through the protocol, what I think Dr. JP Hong was talking about, what they're doing in Korea is they're doing 2 tests, one 5 to 6 days before and one just the day before surgery. And then they're not using PPs. Because
Anjana, but it's taking 48 to 72 hours for the reports to come back for a problem. We have a problem with reporting. So we kind of have to figure out some kind of a protocol, how we are going to test these patients, or alternatively, just keep them quarantined for two to 3 weeks before the operation, and just make sure that they're in isolation. And then the over here a single test costs 4,500 rupees, which is also quite an expensive issue.
Actually, nothing is foolproof. Dr. Ramkumar, you want to say something?
That's right, Parthu. Between I think Manish and Hitesh were at one end and Luis at the other end, we have a spectrum of ideas that have come up to deal with COVID patients. But in addition, I just want to add that most centers do these surgeries on spontaneous breathing. And as opposed to a controlled ventilation, when you do a controlled ventilation with an uncuffed tube, as Manish was talking about, the chances of the aerosols and virus particles coming out are much higher. And I think none of these would therefore be protective, except if you have an N95 mask and you tape it all around, make sure that you're completely sealed off. And I don't know how comfortable that's going to be for the surgeon.
Ramkumar, can I ask you, do we have to use uncuffed tubes, or can we switch to cuffed tubes, and are they safer?
No, we can switch to cuffed tubes. In fact, some of the sizes are not available. Very small babies, they're not available. But fortunately, I think starting from 3 or 3.5, it's available nowadays. So if it's a small for age baby, then we might have a problem. But otherwise, I think one additional thing we can do, Manish, is put a throat pack anyway. That would kind of act like an additional barrier, and maybe minimize the amount of aerosol that's happening. But it's a big risk, and I think looking at what Manish was suggesting of quarantining people for 2 weeks may be very, very difficult in most situations. What do you think, Manish? I mean, I thought you suggested that we should quarantine people.
I think they should be. Well, it's a cheaper option. I think by delaying the operation by 2 to 3 weeks, it's no big deal.
That's true.
And you can put them into isolation.
It's kind of supervised, right? So supervised quarantine, that would be difficult, I think.
Yeah, so we've kind of made up a protocol.
Yeah, I think Louise wanted to share some photo of how she operates now. Can have that.
Did you receive the pictures, Anjana?
No,
Did you get the pictures on your phone?
Put it on your screen and share your screen.
Okay.
I think
I sent it. Let me see if I can. It's on
Something
WhatsApp. I sent it on WhatsApp on your phone. Yeah, that's it. I can show you the lateral view.
Okay, so
No.
anything else to talk about?
I think we are done, so you can give your concluding remarks, Partho.
We have already concluded.
Okay, so I thank everybody for participating, especially Louis, who's I think early morning in Canada, taking time off to join us. And of course, Hiteshwar and Partho and Monish, who all put in the inputs. Thank you very much for a very good session. So we hope to do the bilateral next week.
Thank you.
Thank you.
It was a pleasure to see you. It's been many, many years since I saw many of you. It's a pleasure. Take care. Bye-bye. Bye.
Bye.